All right, welcome to the Last Visit First podcast studio. Today, my guest, Jay Duty, COO at Maxwell TEC. We're going to hash through this 2027 proposed CMS rule on home health. So CMS just proposed a 2.4% payment increase for home health in 2027. If that's the only number you take away from this, you're missing a lot. So pay attention. Today, we are unpacking what is actually happening underneath the headline, a temporary rate cut, a nearly $5 billion recoupment, a full case mix recalibration, all landing on the same rule. So this is going to be Jay and I going back and forth talking about this. So, every software vendor, every consulting company, every law group are all putting out articles and press releases and things like that around the 2027 proposed rule. And I like to sit down and just chat about it and make it a lot easier. So if you're a listener, if you like to read, we'll put some documents out you can read. But if you want to hear us and you want to talk about it, we'll just do it through a podcast and we think it'll be better. So Jay, welcome to the show. Let's get going here. Give us the 60-second version of your background and how you ended up focused on home health reimbursement policy. Tell us who you are, what you do.
Yeah, actually, the first 10 years of my career in the hospital business. So I worked for HCA for about 10 years and then found my way to post-acute care through an accountable care organization and then moved into the industry. So I did strategy and development there in home health and hospice for many years and then was fortunate to find Maxwell and been enjoying working with the team there with you and Jeff.
It's awesome. All right. Well, then when a rule like this drops, what's the first section you turn to and why?
Yeah, first is the headline numbers, right? You're going to see typically it's been a cut, right? So the past 5 years, I noticed kind of the symmetry of it is like, it was almost 5, almost 4, almost 3, almost 2, almost 1. And now it's, not a permanent adjustment. So that's what we've seen over the last few years. So when I first see it, that's the thing I look for is what's the damage usually.
For sure. Let's break down that 2.4%. What's actually driving it?
Yeah, so the 2.1% base payment rate update, so to the good, 2.1%. The rest of that 0.3% is in the fixed dollar loss ratio, which kind of clearly stated it's a 0.3% kind of backstop for those high acuity outlier patients. So that's not going to affect too many people, but the headline number of the 2.4 percent is updated. But a big part of that, about $50 million of that, has to do with that fixed dollar loss ratio for those high acuity patients that cost a lot of money to take care of. So not quite everybody's going to see that same impact for sure.
Yeah, we saw a lot more of the outlier payments, 10 years ago, a lot more changes around those. But these are really your, twice a day visits, your BID diabetics, these patients that require tons and tons of care. So most people don't have a lot of outliers, less than 1 or 2%. So yeah, that's kind of a secret number in there. When you roll them all together, you say, oh, wow, it's a lot better than you think. But most of those patients don't impact you. So,
and a big part of that too, again, buried in the headline. Again, I look for that headline first, but the 3%, adjustment, temporary adjustment, which is great. And part of that 60-second version is there is a temporary adjustment of 3%, but there's no permanent adjustment, which I think is really good for the industry. And again, that trend has been just under 5, just under 4, 3, 2, 1. So kind of going down a little bit since the 2020 PDGM payments coming in. So that's good news, but I put a little bit of a question mark behind that because I think there's a lot to it when you really break down the details.
Let's talk a little bit about if you were advising a CFO. Maxwell TEC advises a lot of CFOs. What's the one sentence you would want them to remember instead of the 2.4% figure?
Yeah, I think it's the temporary clawback, right? So I think for most agencies, that's going to land somewhere around flat. I would approach it kind of in the reverse is, engineer the 3% reduction and then kind of start to build back in what's your case mix, what are the LUPA thresholds going to mean to you as an individual agency. So whether it's like a multi-site, all over, you're going to have to look at that kind of branch by branch specific to your patient population to understand the impact. So that's the advice I'd give to a CFO is begin with the end in mind. So think about it as a 3% reduction on that temporary adjustment and then build back in what your agency actually looks like.
Awesome. Talk about that behavioral adjustment. Explain that. Why do you think CMS, I mean, you and I both know what's going on here, but what's the real story behind that in your mind?
Yeah. So in 2020, when we moved to the PDGM model, there was a period of time between about 20 and 22 that they built in the coding intensity, the visits, LUPAs, all those case mix weights, all those things that matter there. And what they said was, and I think this is kind of the flawed methodology part that the industry's been talking about, is they kind of assumed there was going to be this bad behavior and that they needed to adjust for that. That if they put in this model of PDGM, everybody was going to shift and react to that and therefore change their behavior. The thing I don't like about that is like it assumes bad intent or bad behavior. Other thing I think we find ourselves, now we're going into a calendar year 2027 rule that we're living off of old behavioral assumptions there too. And in the meantime, the industry's gotten more efficient, coding's gotten better. There's a lot more tools out there to kind of true up the true like regulatory compliance of coding and of documentation on the clinical side. So, they're going to assume this bad behavior, but it didn't assume that what if the industry actually got much, much more tight and better and had better tools to do that. So we're living off, I think, of an old chassis on this rule too. And so I hate that we're still kind of feeling the effects of that too. So they have statutory authority to adjust rates permanently or temporarily as they see fit to get what they see as like a spending back in line there too. So they looked at like, what did the industry spend? And hey, are they going to make all these changes and kind of zig to the zag of what the regulations are too? I just think there's not a lot of fairness in that to just assume people are going to behave a certain way and punish them for that without it actually happening.
Let me give you an example. We looked at a lot of data under the Mosaic Pulse product, and we started looking at a lot of these therapy-only cases. And the therapy-only cases under this 30-day methodology that CMS proposed back in 2022 around the billing periods. And we see tons of patients, they get hip replacement or knee replacement or shoulder replacement or shoulder surgery or whatever that orthopedic surgery is. They get 30 days worth of visits, or they get 15 visits in the first 30 days, but they discharge and go to outpatient rehab prior to the 30th first day. And so the agency thinks they're getting, $3,000, $4,000 for this, super intense care and therapy care that they're doing. But really they're only getting the $1,800 or $2,000 because they didn't get to the second billing period. It's really caused a lot of pain for a lot of people. And then we're starting to see this more and more and more where, doctors are putting patients into home health for the first 30 days and then moving them to outpatient therapy. And those are really, really expensive episodes. Now you take a haircut on those as well. It really gets expensive. So you may do 12 visits in the first 30 days, really trying to get Nana, back moving or, up and walking and those kind of things. And they discharge her to outpatient rehab and the home health agency loses money on them. It's pretty wild. So that clawback is $4.9 billion is what they said. Explain that. That's crazy.
Yeah. I mean, that's the temporary adjustment we talked about. It only affects the rates of the year that it's applied in. So once they're going to get that back, we've reset that over the years of the permanent adjustments coming in. I think they like this temporary route because it avoids them having to go explain their methodology and talk about how they're getting that recoupment back. It's just a large permanent cut, says there too. So 500 million of the 4.9 billion balance is 3% of that too. So 10%, right? So based on what the CMS has said and what they've described as their approach, it's expected to be looked through temporary adjustments in the future. They should expect the first several years of that to continue to put down your pressure on that. It's not just one-time event. So we should be looking at that to plan for those adjustments coming in the future too. So you're going to take 3% on a temporary adjustment. And again, just because there's a 2.1% raise and then a fixed dollar loss ratio of 0.3, that doesn't mean that all these agencies are going to get there too. So there's a lot of muddy waters that are going to come in there that are going to be agency specific. That's going to really cause these agencies. I think everybody needs to go look at their individual profile. Who are we? What kind of patients are we seeing? How does this really affect us?
Yeah, if you're not modeling your data today, you should be. I mean, depending on your EMR and what you use, I know there's a couple of the EMRs from Caribase. I know one. WellSky does this as well. Others is they actually load your data as it is today into the new payment amounts and then allow you to review that data and see where the impact's going to have. If the rule comes out as final as it was proposed, here's the impact it's going to have to your organization. Are you going to make money? Are you going to lose money where you're at? Don't forget about the wage index. There's some adjustments they're going to make around that too. All right, let's jump into this little bit controversial question. So CMS says the data from 2022 forward is too muddled by case mix recalibration and OASIS E transition to isolate pure PDG and behavioral changes. Do you buy that argument, or do you think CMS is just picking data that supports the recruitment it wants to make?
Yeah, I think you could probably, this is one of those debate questions that you could probably argue either side of it, right? So, OASIS documentation and recalibration of that, it has merit to say, like, here's the care that's been provided, and they've got a documented kind of path of that. But we're looking at that from data from 20 to 22, and we're applying it in 2027. So that assumes that there's been no improvement. It assumes that there's not great defensible reasons clinically for this behavior too. And so if you it's going to muddy it with our PDGM, clinical groupings and those kind of things. I think looper rates also is a very interesting change in this that we'll talk about. I think there were 18 different looper rates that were shrunk by one visit, which is a lot when you're talking about low utilization, right? One is a lot in that scenario. So I think you're going to have to document very, very well the care that you provide. And we're going to have to comment on this too, because again, I think this is where the industry advocates have been really active, and the current administration, I think, is willing to have the conversation. Is we're talking about behavioral adjustments on data from 2020 to 2022 that we're making these decisions on now in 2027. It just seems like there's been enough change and improvement in the organization, in the industry since then.
Well, not that you have all the technology changes, and the EMRs are getting better at capturing the data and making sure that we're answering the questions right, and the validations are there. And now we have the new introduction of AI and Scribe, and so people are doing like companies like Steno and Apricot, and those guys are using AI and Scribe to help make sure that the data is documented. And then you got all these companies that are doing the history and physical assessment prior to the start of care to make sure that we're not missing anything in there. So we're getting more and more accurate in the OASIS data set. So why wouldn't you use a more accurate OASIS data set to do your calibration of your numbers? It makes no sense to me. All right. Everybody needs to respond to this in the industry. So most people are going to write comment letters or add their data or feedback into the comment letters. And I highly recommend you do that if you're listening to this. And we will as well. So Jay will write us a comment letter, and we'll lean into that, the Alliance and, some of our other bigger friends that are out there that are doing this. But if you were writing the industry's comment letter in this section, what would be your strongest counter argument? Like, what would you say in there?
That data, I think, is the first, second, and third answer to that. The methodology used to get there, is, I think, a little bit, acuity is a little bit wiggly in there. Like you said, in all this documentation, you may have a 16-page document that's coming, at the start of care, and somebody didn't go mine every little bit of, oh yeah, there's this and there's this, and oh yes, that does that too. And so I think some of these tools are help highlighting this is what the patient looks like when they're coming on service there too. There's a lot of rich information in there that, a human that's trying to move fast, trying to get a patient on service and admitted, and they're not going to be combing through every little detail of that, in real time. And so does that help you get there too? So I think that's one. I think if you look at, again, the several data, the methodology question, how is that relevant to today? And then, what does the adjustment stack with the case mix on top of that look like, especially in these rural areas and high cost markets where the wage index is much, much higher, providing that care is much, much higher. What are we weighing whenever we're looking at this kind of in total with all those different factors together? So,
yeah. So let's talk about budgeting process. So this rule, first of all, I'll explain it. So the proposed rule comes out right around July 4th, always, by the way, always runs by July 4th. So that happens. And then we go into this comment period, and then CMS takes all the comments that we give them. They review those comments. They essentially rebut the comments or define the comments or write a response to them. Then the final rule comes out, hopefully right around November 3rd is usually when it comes out. I used to think it was a law that they had to give you 60 days to implement, but we found that out last year because the government was shut down. We didn't get 60 days. So somewhere around November 3rd, you're going to get the rule. Every home health agency that I'm a part of, that I've worked with, has a budget cycle, and that budget cycle starts in September and usually gets finalized around October. End of October, it gets sent to the board or to the leadership teams to approve, and then they approve their budget for 2027. This rule is going to come out prior to you finishing or after you finish your budget. So if you're a CFO or you're the finance team at one of these home health agencies, talk to us about how you model this so that you can be prepared, so you can create an appropriate budget so you don't miss budget next year because you didn't have all the right data.
Yeah, I think I would do it. I would start with, again, kind of in reverse, that, the 3% reduction to get a realistic kind of net rate change before your case mix comes in there. So then you look at your coding distribution, case weight mix, LUPA thresholds, comorbidities, your clinical groupings, some that'll gain and some that'll lose, and then look at that blended kind of patient level data. And I think you can't even do that on just kind of the average of your, especially if you're a multi-site, multi-state agency. You can't just look at the averages of all of that. You need to really get a picture of what does it look like in this region? What does it look like with these wage adjustments in all those regions, and then add in your 2.1% base update there too. Because I think you'll get, I think a lot in large part every year when these come out, kind of up or down, tends to be relatively flat what the average agency sees. So, really even the cut is still a cut, and what we've seen over the few years, especially with the permanent adjustments, and that's what's really driven that. But it tends to be that a lot of these different clinical groupings, and I think it's kind of intentionally muddy a little bit because they're just looking at the entire Medicare spend on the whole and making those assumptions there, and the patient base as a whole. But you got to build it around what you're actually seeing. So I don't think it's going to hit everybody evenly. You got to look at your geography, your patient population, the payer mix, all those things that are going to take effect there.
Yeah, for sure. And then you also got to remember that a lot of these agencies historically were 80, 90% Medicare. Now they're, more patients are on Medicare Advantage plans or commercial insurance plans or different kinds of plans. And so now your population's not 100% Medicare. So so now you're creating a budget. You used to create a Medicare budget or a CMS budget. That was what your budget for your organization. Now you got 50% of your population's on Medicare Advantage or a different program. Maybe 60% is Medicare. So 40% is different. Now you're going to model that. And then as you create your budget, you got to figure out how to model. Is that going to flex up or down? Am I going to take more Medicare Advantage, less Medicare Advantage?
Yeah.
Where are my referrals coming from? Where's my phone ringing at? So I think the budgeting process actually just gets a lot harder with all this stuff. All right, let's talk about visits a little bit. So we're seeing the average visits for 30-day period, so that PDGM period, fall from nearly 10 in 2018 to 8 in 2025, while we're still having more comorbidity documentation intensity and we're seeing sicker patients. Is this changing because more accuracy or more pressure, or what do you think? What do you think is causing that change?
I think it's a little bit of both, right? I think some of it is we've done a little bit better job in training on documentation on the clinical side for OASIS. The EHRs have driven that documentation and have improved the capture of those comorbidities over time. And I think there probably are more complex patients coming home, which is something that we've said as an industry we want to achieve. Is we want to bring these patients. These patients want to be home. We want to get them there. It's interesting to me that the visits are declining, the number of the visits. That means that there's a lot more going on, a lot more that needs to be documented, and actually less visits. And so that's interesting. I think that also a factor that's, I can't show you this in the data today, but the pressure on staffing, right? That has to be part of this. It's not just that people have really streamlined visits. And we're really trying to find the right staff to get in front of these patients as well as we can. It's not a supply problem from a patient standpoint. It's more of a demand problem of our resources. And so as an industry, so it's an interesting visit decline. I would love to talk to people in the industry, and I plan to have these conversations, pretty quickly. What are you seeing? Are there less visits because you're able to do less visits? There's also more restrictions on the payer side of that too. That should be separated apart from the Medicare side. So I think we're getting better at documentation. I think we're being asked to do more per visit, more intense documentation, more focus on that specific patient during there instead of just a bunch of subsequent visits. And again, that's a dwindling resource. So getting those nurses, therapists, whatever discipline needs to be in front of those patients timely and regularly is continues to be something that's seeing a lot of pressure.
Yeah, I think we're really becoming more intentional around the visits, right? So let's really get out there and be intentional at the visit. And technology's helped a ton with that. Like we can check on patients via text message. We can put in different kind of monitors and those kind of things to monitor patients. And I mean, I think being really intentional about the visits that you're doing. And I mean, if you get the same outcome by doing 8 visits versus 10, awesome. But if the outcomes start changing, now we got a problem. All right, let's talk a little bit about on the finance side, agencies with debt covenants or investor reporting tied to Medicare growth. What should they be doing right now before this rule comes final?
I think that revenue projections, if you're looking at that, again, 3% reduction on your base rate, that's a downside scenario at its core. And so you've got to look in and talking to investors before the final rule lands, understanding, hey, you're seeing this headline number of a 2.4% raise. don't go in there and run your financials and just add 2.4% to it and feel like that's the end of the day. I think you've got to have a sensitivity model that's really driven around. I know I sound like a broken record, but your specific patient population, what you're seeing, the clinical groupings they're in. I would be communicating proactively with them to get an understanding that, hey, let's just not all high five each other and say that we're going to be, to the good. It may depend.
Yeah, the media kind of blew this thing up as it's a real positive. Home health's getting a big raise, and I know you talked about the multi-site, multi-state, multi-branch. I mean, it's crazy when you start really looking at your branches based on the case mix weight, based on the wage index, based on the cuts that are coming, positive or negative. I mean, you can have major swings here. It could be 5 or 6% up and down, or 4 or 5%. Remember, the headline was all Medicare patients are getting this pay increase, but when you really start diving deep into your locations, I've seen some in the past where they were getting an 8 to 10% cut just based on the how they set the wage index up. So focus on that, pay attention to that, make sure you're looking at that. All right, let's talk about the parts that everyone else will miss. So CMS is looking or asking for public input on the home health specific wage index. Explain what you think that means. Why does it matter? And what would a good outcome actually look like for agencies in high cost labor markets?
Yeah, I think a lot of people probably already realize this, but we're actually built on the hospital wage index too, and not a home health specific one. And so again, that's where we'll ask you to comment is the pros and cons of putting a model out there. If you think about some of the major disciplines that we really utilize in this space, outside of nurses, therapists, you've got home health aides, LPNs, therapists whose labor markets don't always move in the same way as some of those RN wages or therapy wages there too. So it makes a lot of sense to me that we really need to look at building something directly for home health makes a whole lot of sense, especially in those high cost markets. I mean, there's definitely markets that are high cost that also, oh, by the way, have a lot of scrutiny on them right now. And so the intensity of what's having to be documented in those settings and what that looks like is that much more focused on and is more intense. And then rural markets. I think the advocates for the industry, the Alliance and others have done a really good job. Remember those rural markets where you may be able to list the number of nurses or therapists or home health aides, on one hand, and their names and that you've got to go get them, but it's not, those resources don't just grow on trees. And there's a lot of patients in those markets that need our care. And so those aren't kind of a one for one resource or supply to demand kind of ratio there too. So I think it's got a lot of merit for us to look at a home health specific wage index.
One of the guys I serve on the board with at Tango's, his father was looking for home health. He lives in upstate New York, not way upstate, but kind of north of New
Yeah.
York City. Couldn't find a home health provider. He needed one. He paid it. It was a Medicare benefit for him. Couldn't find a provider. And there was one agency in the county. It was a state agency, and they couldn't take any more patients. They had a waiting list for like 6 months, and literally he had to go out and hire a nurse, a human nurse, to be his on staff for him. And she was a lady that was at the hospital that would come into his house. He's like, my dad deserves home health. He's 80 or something years old. He's paid the Medicare benefit. Couldn't get anybody to take care of him. It was crazy because he called me. He's like, hey, can you help me with this? I'm like, sure. I'll pull up a list. I'll go control the data, figure out everybody in New York. Nobody could take that county. And they would have to drive 3 hours to get to his dad. Like, well, first of all, I want to move your dad in the middle of nowhere. But second of all, there's no healthcare there. So it's pretty wild. Okay. CMS also in this one, and this is headline, the parts everyone else will miss, but I don't think everybody's going to miss this one. But they also expand on their authority to deny, revoke, or bar reapplication for Medicare enrollment, regardless of the reason for denial. So their words in there really mean a lot, regardless of the reason for denial. How much attention is this provision getting relative to the actual risk for providers?
I think it's getting less attention than it deserves. I know we're seeing in the consulting world where, there's whole provider numbers that are completely under scrutiny, billing being completely paused. I think that you're hearing all this about fraud and, I think the industry at large supports that because nobody wants that. We all feel like we're providing great care there too, but there's pretty wide ranging, latitude here for CMS to have the authority just to not allow somebody to reapply. And you're going to have to be really making sure you're timely on that you're, the survey issue, you have those survey issues, make sure you've got your plans of action in there. You want everybody to be looking at this and not just the finance team. So those with like past billing, licensure, survey issues, those kind of things. you're going to carry this risk that you could really be affected, that you could lose your Medicare enrollment, and that ends the business entirely. So it really is. I mean, I don't think this is, total gloom and doom or, hit the red button, but you really need to be thoughtful about that even when you're reapplying to Medicare too. So the payment issues get the headlines, but there's a lot of scrutiny right now on just provider numbers in general. Obviously, there's a moratorium that potentially could be extended through this, and so there's a lot of that language in here. It feels like that there's a lot of latitude.
I totally agree. And have your lawyer read this one. All the industry advocate lawyers are reading it. This is an area of real scrutiny that we've got to watch out for. All right, let's jump into some advocacy stuff. So the comment period runs through August 31st of 2026. Realistically, how much can the industry comments move a provision like the behavioral adjustment clawback before the final rule is published? Everybody's done it for the last 20 plus years that I've been doing this, 21 years now. We see a little bit of action in that, but I mean, do you think if everybody comments, we'll get more action, or where do you think this is
I
headed?
think so too. The thing that stands out to me is just how few people comment. I mean, there are, there's been years, there's calls by everybody to do this, and people say, "Oh yeah, yeah, we need to do that," or maybe they do the letter that gets generated. I think that's a great tool that kind of auto-generated letters to your congressman and all of that, which is great. But just thoughtful comments, will go a long way. Data driven, I think, is the other thing too. I don't think that it rarely happens that they're just like, okay, never mind, we're not going to do anything like we proposed. But we have made some headway and making sure that we have meaningful influence there too. It's either the size of the cut or the the pace of how quickly those are happening or how much they're pulling in the temporary adjustments or in the permanent adjustment. But yeah, we've got to give well-documented data-driven pushback to really show the magnitude of what these regulations cause to the industry writ large.
And I think we got to be aligned, right? You can't have one person commenting, the sky's blue, the other one says no, it's actually pink. It's right before sunset, and those are wrong. Those are different. They're same but different. So we need to be super aligned. So I advise people to reach out to the alliance if you're part of the alliance or whatever other advocacy group you're part of, but make sure we're aligned on these comments and make sure they're kind of all fighting in the same direction or pushing on the right things.
Time will tell as everybody coordinates too. But I mean, there's the 3% temporary adjustment. I mean, that seems like a place that we should start and show the reasons why that doesn't make sense. The methodology doesn't make sense. The actual care being provided makes sense. Access to providers and care that doesn't make sense there too. We've got to incentivize some of these larger multi-state agencies to be in some of these more rural areas providing care, because a lot of times, to your point about New York, there's either nobody or a very few amount of providers there that are able to take care of them.
So if I'm an agency executive, if I'm the CEO of a home health agency, and I actually want to submit a comment letter versus just complain on LinkedIn, about how Medicare is hosing us over, what makes a comment letter valuable for CMS? Which ones are going to really, change the game?
I definitely think the data-driven piece too, and I think a lot of times whenever we see the proposed rule, it comes out, around July 4th, which, kind of probably contributes to less people reading it word for word. And then the final one comes out in Halloween. And so it just happens to be that those are about the time of year that the statutes require for those to roll out. So,
Do you really think they coordinate that? Do you really think that they figured that out? They
I mean,
have to, right?
it seems like every July 4th weekend, that's what happens. Happens to be my birthday weekend. So it always is like, yeah, I could read that word for word, but it's a pretty thick document. I know several people that do, and I appreciate them for it there too. But I think if you see that and then you just see those headline numbers and just take to LinkedIn and throw something out and rage against it, that's great. But let's put some real thought into actually sending a comment to CMS, something that's data driven, thoughtful. You said it's a very good word, aligned with the other people that are commenting as well. Let's have a defensible methodology to counter that, not just whining about it to CMS saying, oh, this isn't fair, but have a defensible methodology that you're saying, well, this is a way that you could objectively look at this. And here's what we're actually seeing. And here's the data to show you what it looks like when we're actually out here providing care. Here's what it means for us. It's not the headline number of a raise. It's actually tough for us. And the wage index, affects us or doesn't help us enough in some of those areas. So yeah, I think that's just instead of raging, just actually take some time to send a thoughtful, you know, true comment letter to CMS.
Sure. All right. Zoom out a little bit further. 5 years from now, does this behavioral adjustment true up a mechanism still exist in this form, or does something else that structurally changes at CMS?
I mean, I feel like they've got they feel like they have statutory authority to do it. So CMS is going to, I hope, become more thoughtful of that. But in an environment with increased scrutiny, this is kind of a way to do that. And so they're kind of thinking through a way to reduce fraud is to continue to be more stringent on assuming, behavioral models that are not actually based in reality. But we've got to coordinate together and talk to them. I think the behavioral adjustment, I think it's 5 years. It's impossible to know. I think 5 years is an eternity these days, and we've got to figure out how to sing their song and provide regulatory compliant care that these people really, really need in the home that's documented well so that we need to kind of police ourselves so that it's not coming in with this behavioral adjustment, making sure that we're documenting the acuity of these patients. I think patients are largely, more in need of our services in home health and hospice than we're documenting. But in home health especially, I think there's a lot of meat in there in the clinical documentation or the documentation you get with orders or face to face from prior to the stay that there's a lot of meat in there for those clinical groupings too.
Sure, sure. All right. Just another reminder. Comment period closes August 31st. If you want to jump on with us and let us read your comment letter, or you want our help writing your comment letter, or want to reach out to your software vendor, I'm sure they're all going to respond or write a letter. So I'm happy to help anybody that wants to do that, as well as, we'll guide you through the process if you need it. Last question. If you're an agency owner, operator, listening to this right now, what should you be doing this week, this quarter, this month? What are you doing right now?
Yeah, I think it's not too early to start running your model. I think that if you can run a model today that's driving those comments to say, hey, this is how this would really affect us. You can get that in before August 31st, at least to have some high level modeling to say, here's what it means for us. Here's what the headlines say. I think that has really a lot more opportunity to influence CMS than just, hey, this isn't fair. So yeah, it's not too early to do that, especially looking at the clawback and starting there and just seeing what that means, and then add your case mix to it, clinical group distribution. Don't just throw a national average in there and say this is what my model looks like, but put some thought into it.
And I also think people need to start, figuring out how to cut costs, right? Centralization processes, whether it's intake or scheduling or back office, QA, QI. How do we reduce visits if we're going to have to reduce visits? If Medicare is only going to pay you this amount of money, you can't spend this amount and no money, no mission. And so you got to figure out how to start working on all those things, make your documentation faster, quicker, better, implement, these scribe products that are out there that are making nurses happier, figure out how to be more compliant, check all the right boxes. It's going to be super important. All right, Jay, if someone wants to reach you, how do they get a hold of you?
Easy, Jay at maxwelltech.com, maxwelltec.com. Would love to talk to you about it. I know a lot of people are looking at, hey, we got to optimize what happens in front of the patient, in the back office, through our billing processes, all of those too. So appreciate the time today. And yeah, Jay at maxwelltech.com. Love to talk to you.
All right. Yeah, or go to www.maxwelltech.com and just respond there. And I promise you someone will reach out and talk to you. So appreciate your time today, Jay. Thanks for giving me a good 35 minutes of knowledge and brains. And we'll distribute this and we'll do another one of these. We also love any comments on these. If we said something wrong or you want more or you want less, we'd love to hear what everybody thinks about instead of doing a document using AI to write this thing up, we just get on here and talk about it. We think it makes more sense and it's better for people to listen to it or watch it. And so appreciate everyone attending, showing, and commenting, subscribing. If you haven't subscribed to our podcast, please do. Thank you.
Thanks for having me.